All right, so ammonia. We've talked a little bit about ammonia, sort of, but ammonia is made because of essentially protein that's in your GI tract, right? So here's protein. Well, let's actually move it down a little bit. So protein within our GI tract. So here's our protein down here. And little microbes, of course, digest this protein. Those are microbes. And they convert that protein into ammonia. Right? So we have ammonia being produced by the bacteria that are in the GI tract, and this is true in the GI tract of all animals. And then that ammonia, right? So you can see the vasculature. So here's more vasculature. So all of this is draining the intestines. And so it takes this ammonia via the portal vein, right? And it sends it to the liver, and then the liver processes the ammonia. And how does it process the ammonia? Well, here's a hepatocyte. It takes ammonia, and via the aptly named urea cycle, it converts it to urea. And of course, urea is dumped into the circulation, and we excrete urea, of course, into our kidneys. So here's our kidney, and the circulation, right? So here's our circulation, and the urea leaves via the urine, yeah? So we all know that. We reabsorb some urea, but we excrete a lot of urea. So the reason urea is one of the indirect liver function tests is because, of course, ammonia has to be converted into urea via the urea cycle. And I'm not even going to write that because you don't have to know that. And so ammonia then is our direct liver function test. Urea is our indirect liver function test. And so we look for increases in ammonia as a sign of abnormal liver function or abnormal liver blood flow. So let's talk about that. So if greater than 75% of your normal hepatic tissue is dead or just not working, so essentially normal hepatocyte function greater than 75 to 80% loss is going to result in hepatic failure, and you'll see an increase in ammonia. Ammonia is harder to measure, though, than bile acids, so we can see increases in bile acids, increases in ammonia, and then those abnormal indirect liver function tests. And this is because you have a decrease in functioning hepatocytes to convert ammonia to urea. So you're probably not going to start with the ammonia test because you have to run it right away, so it's not always the easiest thing to do in practice, certainly. So that's cause number one. Cause number two is abnormal circulation. And so if you'll realize, these are very similar to what we see in with increases in bile acids. So abnormal circulation means that essentially you have a portosystemic shunt. So instead of ammonia being taken up by your portal vasculature, there's a bypass that happens, and it goes directly to your heart instead of your liver. And so you're going to see increases in ammonia in your blood. And so this is, again, a portosystemic shunt. And we can see these can be congenital. We see them in young animals. Small breeds versus large breeds have different types of shunts, which I'm sure you went over in the systemic path course. It can result in a very small liver because of less nutrients getting to the liver because of abnormal circulation. So that's PSS. We'll see increases in bile acids again, just like previously. And you can also have acquired portosystemic shunts, which are secondary to chronic liver disease. And that means that instead of kind of one big shunt that occurs, you have abnormal vasculature that forms secondarily. We're mostly going to focus on the congenital portosystemic shunts. So these are kind of the two more common ones. We're going to talk about one third one. Urea toxicosis in ruminants also happens. We're not going to talk about that. And so severe GI disease in horses always have to be different. They're kind of like cats. because horses often get GI disease, yes? And so, since they have so much GI tract, if they have really severe GI disease and tons of bacteria converting this protein into ammonia and a degraded GI tract wall that hasn't actually killed them, you can see increases in ammonia. If you see this increase in ammonia, you're not going to expect to see, so liver function is going to be okay. So this has nothing to do with actual abnormal liver function, so it's okay. You're just going to see inflammation, potentially. Of course, you might see a low calcium because they're so dependent on their GI tract for calcium. They might be neurologic from the increases in ammonia. So those are the big things. And of course, they're going to have GI signs. They love to have an overwhelming inflammatory leukogram that goes along with it, but they'll be very, very colicky. So the main thing you're going to see related to the liver is an increase in ammonia. Notice the one thing that's lacking on this that we had on bile acids was obstructive cholestasis. That's because ammonia has nothing to do with biocanaliculi. So ammonia has nothing to do with actual bile circulation. It's all blood circulation.